evening to all the eminent faculty members and participants from various parts of India and as well as abroad. I welcome you all in today's webinar. And I'm Dr. Nishan Prajapati from Zydus Life Science Limited. And on behalf of Zydus, I welcome our guest speakers for the evening, Dr. M.B. Agrawal sir, Dr. Neeraj Arora sir, and Dr. Nitin Sood sir. Before we commence the proceeding, I would like to welcome and introduce the host and the convener for this continuous medical education series under the aegis of Mumbai Hematology Group, Dr. M.B. Agrawal sir. Dr. M.B. Agrawal sir is Professor and Head, Department of Hematology, Bombay Hospital Institute of Medical Science. He is also associated with other esteemed institutes as well, like PD Hinduja Hospital, Lilavati Hospital, Fortis Hospital, and Bridge Candy Hospital in Mumbai. He is the president of Mumbai Hematology Group as well. So without further delay, I invite and request Dr. M.B. Agrawal sir to navigate this program further. So sir, over to you, sir.
Thank you. Good evening to one and all. This webinar is brought to you by Mumbai Hematology Group. It is supported by Zydus and Glenmark. It's managed by Perfect Square. Our guest speakers today are Dr. Neeraj Arora from Ahmedabad and Dr. Nitin Sood from Gurugram. I'm grateful to Team Zydus and Glenmark, Mr. Yash, Mr. Kalpesh, and the Team Perfect Square, Executive Committee of Mumbai Hematology Group, both the guest speakers, Dr. Neeraj Arora and Dr. Nitin Sood, our discussants who are themselves eminent hematologists, medical oncologists, and hematopathologists, and you participants for sparing your Thursday evening. Tomorrow, we have an extra webinar. 6:30, we have Dr. Vishal Jaikar from London. We're going to speak to us on EHA Highlights 2026. Dr. Amit Khurana was instrumental in getting Dr. Vishal Jaikar for this webinar. I'm thankful to him. This will be followed at 7:30 by Dr. Nasima Gangat from Mayo Clinic, Rochester, Minnesota, US. She will speak about, once again, an update from EHA 2026, specifically on myeloproliferative neoplasms. Coming to our first guest speaker, Dr. Neeraj Arora. We all know him, the molecular hematopathologist. He is MD in pathology, followed by PDF hematopathology and PDF molecular hematology. He is director of molecular biology at the Unipath Specialty Lab at Ahmedabad. He gave his services to Tata Medical Center, Kolkata for long 7 years. Prior to that, he had worked in the Department of Hematology at CMC Vellore. He is instrumental in setting up affordable diagnostic molecular techniques for both hematological and solid tumors using the techniques like NGS and digital PCR. Today, he's going to speak to us on a very important subject, which is very confusing, is JAK2 negative erythrocytosis. So I'll stop here and hand over the platform to my friend Neeraj.
I hope everyone can see my slides.
Yes.
Yes, sir. So at the outset, I would like to thank sir for this opportunity. Thank you so much, sir. It is always amazing to see you going through the details of each and every person, and every time you go through that with same amount of dedication. Thank you so much, sir, always. And the topic for the today's discussion is JAK2 negative erythrocytosis. As sir mentioned, it is a very confusing topic, and indeed this presentation has given me an opportunity to go through many of these things. And also I would like to thank two people for this presentation, because Dr. Varun Bafna and Dr. Priyanka Samal. Actually, whatever I am going to present has been initiated by these two people. During my discussions with these two clinical colleagues, they kind of shared their problems and issues, and that is what guided me through this topic. And I'll share some of the work in this area. So let us start this topic. So JAK2 negative erythrocytosis. So let us start with erythrocytosis. What is erythrocytosis? We all know that erythrocytosis is a blood disorder characterized by increased red cell mass, elevated hemoglobin, and elevated hematocrit values. And these are above the established normal sex, race, altitude adjusted values. So all these values which are increased above the normal values is what you would have in an erythrocytosis. Typically, the thresholds have been defined for polycythemia vera, and this is 16.5 gram per deciliter for males and 16 grams per deciliter for females. And this has been a recent update in the 2022 WHO and ICC classification. Earlier, the values were on the higher side. And probably this decrease in the thresholds is what has initiated a lot of increased consults and discussions. And we are seeing more and more erythrocytosis probably because of this thresholds. And that is where many of us are focused nowadays to be able to see that whether we can get to the diagnosis in all of those cases. So this is erythrocytosis, and traditionally it has been of two types. One is absolute erythrocytosis, another is relative erythrocytosis. The absolute being defined or confirmed by the red cell mass. So if the red cell mass is more than 125% above the average predicted value based on the gender and mass, we call absolute. And relative is where there is a reduction in the plasma volume, but the red cell mass remains the same. So you have absolute and relative. So now the absolute ones is further classified into subgroups, two subtypes. One is primary and secondary. Primary being the erythrocytosis being caused by the intrinsic defect in the erythroid progenitor cells, and those are intrinsic to the erythroid progenitor cells. And secondary being the external factors which help boost the RBC production. So internal versus external. So primary versus secondary, and both of them can be further classified into congenital or acquired. So each of them has intrinsic and extrinsic factors, can be congenital and acquired. And within the primary erythrocytosis, we always kind of tend to have the polycythemia vera as an acquired entity, and that is what we mainly look into with all those established parameters of three major and one minor criteria defining the polycythemia. And within the primary erythrocytosis, you have congenital factors like EPOR germline mutations and SH2B3 LNK mutations in primary. And similarly, in the secondary congenital erythrocytosis, you have mutations in various pathways, which includes oxygen sensitive pathway with mutations like VHL, ELG1 or PHD2, EPAS or HIFA1. So this is one of the common mutations, and you're going to hear this more in my subsequent slides. Then there are additional high affinity hemoglobins. Then there is gain of function mutations in the EPO genes, methemoglobinemia, biphosphoglycerate mutase deficiency. Then there are mutations, SLC30A10 mutations with hypermagnesemia, hereditary increase in ATP, TSO1 gene mutation. So these are secondary congenital causes of erythrocytosis. And then there are a whole lot of acquired causes, which mainly primarily, which includes hypoxia driven. It could be central and renal hypoxia, EPO producing tumors, drugs, and some causes like alcohol excess post-renal transplant, and Tempe syndrome. I am going through each of them because each of them is very, very valuable when you are evaluating them, and you are likely to miss out or not find a reason, and then you have to look for some other causes like even alcohol excess to rule out that. So traditionally, so I have now what is erythrocytosis? I have now what are the uh, causes of erythrocytosis, and now if I want to evaluate general erythrocytosis, so this is one diagnostic flow chart for evaluating that, and it starts from the clinical setting or the history. It starts with the age. So it is what age the patient is presenting with. Is there any family history? So there are a lot of clinical factors which I'm going to discuss more, and probably we are aware that. So with the clinical settings of age, family history, thrombosis, smoking, alcohol, sleep apnea, some drugs, particularly androgens and diuretics, then any malignancy, hematuria. So this is some of the clinical features. So you evaluate in terms of clinical association, and then you do preliminary investigations, and this could include the blood electrolytes to rule out any hemoconcentrations. Then JAK2 mutations, that is of prime importance when you are considering erythrocytosis, because you want to rule out polycythemia, and this is one of the commonest mutations, the JAK2 mutations. Then other important is the serum erythropoietin levels to be able to distinguish between various subtypes. Then you have the arterial blood gas analysis, the venous blood gas analysis, helping you pick up the high affinity hemoglobins, ultrasound to rule out the various malignancies, then hemolytic and iron status, splenomegaly. So these are some of the preliminary investigations and key investigations when you are evaluating your erythrocytosis. Subsequently, you would like to evaluate the red cell mass, and whether it is in more than 125 or less than that. And if we are not able to identify the causes, then additional investigations, which include bone marrow biopsy, respiratory functions, and NGS testing to be done. NGS could be a targeted panel to rule out the erythrocytosis causes, the genes that I mentioned earlier, or even whole genome sequencing also being considered in this pathway. So this is a general good workflow which kind of helps you suspect and diagnose and evaluate the erythrocytosis in erythrocytosis. Now, coming specifically to the JAK2 negative, and this is the topic that we are going to discuss more. So whenever we talk of erythrocytosis, we know that we are probably dealing with polycythemia, and that is what we kind of know with high hemoglobin and hematocrit. And we tend to start with the JAK2 test to see that whether this is polycythemia or not. One point to remember over here is that JAK2, when we say JAK2 mutations, it is not only the JAK2 V617F. So to be able to call it JAK2 negative erythrocytosis, we need to evaluate other JAK2 mutations, that is exon 12 to exon 15, all other mutations as well. Just by testing primarily for the commonest mutation does not mean that this is negative. There are additional mutations in JAK2, and we need to rule out all of them to be able to say that this is JAK2 negative erythrocytosis. And some of the large population-based cohort studies are available, and the incidence varies in many of them. And this incidence varies from 0.13% to 4.1% in a large population-based cohort. So very less number of cases are there. And predominantly male predominance. So you see a male predominance in this subgroup of cases. So this is some bits about the JAK2 negative erythrocytosis. Now, as sir was mentioning that, facing and detecting and diagnosing and then treating erythrocytosis, which is JAK2 negative, remains a challenge. And this is one survey, international surveys, where people kind of evaluated how they treat and diagnose, evaluate, and treat the JAK2 negative erythrocytosis. So the gist is that most of the times you would have only JAK2 being done, and further testing is not done, and it is very, very heterogeneous. No further evaluation and no further uh, 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 diagnosis or any other things are done in once the JAK2 comes negative. So and it is very variable, very heterogeneous. Uh, in most in almost 50 to 60% of the cases, it stops at that level and it doesn't go further beyond that. And there is a lot of causing issues in the patient management, because 50 to 60% of the cases are because of this lack of decision making, confusion, how you want to evaluate, how you want to treat and guide the patient. It leads to a lot of unnecessarily phlebotomy, unnecessarily treatment decisions, which are not aligned with the pathogenic mechanisms which are described. So this is one issue, and this is what is the real challenge that we face. Because as I was mentioning, two of my colleagues, not those two, the others as well, wherever I go, there is always a discussion about what do you do if you have a JAK2 negative erythrocytosis and how to proceed further. And that has been a real challenge in terms of diagnosing and treating them further. So this JAK2 negative erythrocytosis is truly non-uniform and includes rare hereditary conditions, and there are very overlapping and acquired entities which are presenting as secondary erythrocytosis. So as I mentioned, some of the erythrocytosis causes both can be congenital and acquired, primary and secondary. But even going through that, there is a whole lot of cases you still may not be able to find them, and 60 to 70% of the cases remain as idiopathic, where you're not able to identify the exact cause of the erythrocytosis. So, and now there has been a lot of work going on, a lot of descriptions, and few guidelines are also come up in particularly in this JAK2 wild type erythrocytosis. Few mechanisms that has been defined a bit clearly, and I'm going to share some of the mutations which have been defined in this subgroup. So you have erythrocytosis, you do JAK2 negative, and some key mechanisms include the EPOR mutations. So the germline EPOR mutations. Then there are the SH2B3 mutations. So the one mechanism associated with this is the EPOR mutation and SH2B3 mutation. The other mechanism in this subgroup is the red cell membrane defects, particularly the PIZO1 mutation causing erythrocytosis. The third is the mutations in the oxygen sensing pathway. And as I mentioned earlier, the three key genes here, the EPAS, ELG1, and the VHL gene. So these three genes in normoxic conditions like HIF1 along with PHD2 is controlled by the VHL gene, and this helps regulate the intranuclear levels of HIF1. So these are the three oxygen sensing genes and involved in the regulated intranuclear entry of the HIF2A1, and this further forms a complex with the HIF-B1 regulating the erythro-EPO levels here. So any issues here or or any mutations in these two pathways affect the HIF two levels, the internuclear entry of the HIF2 levels, and this leads to the unregulated entry, leading to increased erythropoietin, causing erythrocytosis. So these genes are therefore controlling the HIF level, and VHL being the key gene which kinds of cuts the ELG2 EPAS complex and helps that regulate that. Any mutations kind of impairs the hydroxylation and the degradation of these two genes, leading to increased HIF levels, causing this increased complex, leading to increased EPO level. So this is uh, particularly with respect to the oxygen sensing pathway genes. Then the other mechanisms being the drug-induced level, and here the key some of the key drugs includes testosterone and androgen, SGLT2 inhibitors, anti-angiogenic TKIs, multi-resistant TB drugs, cobalt, and there are various other drugs which have been implicated, and the SIC310 mutations leading to increased erythropoietin, leading to the erythropoiesis. Fifth are some of the tumors, and there are tumors like RCC, hemangioendotheliomas, meningiomas, even the diseases like plasma cell neoplasms. They also can be associated with erythrocytosis. So within the plasma cell neoplasms also, you will always have anemia. There will be anemia associated with various plasma cell neoplasms. So, but some of these syndromes will have erythrocytosis, and syndrome like Poems and Tempe syndrome will have erythrocytosis. And this is because of the paraneoplastic production of this erythropoietin, causing increased EPO and leading to the erythropoiesis. And the last is the EPO gene mutations and the presentation of hepatic like EPO production. So there is it is the sixth mechanism being described under the JAK2 wild type. So these are some of the mechanisms that we have been able to document with clarity, and we tend to look for them when we are evaluating and understanding the causes of erythropoiesis. So one practical, so I try to describe how you would like to evaluate erythrocytosis, then various clinical investigations, and how will you like to diagnose some of the cases. But one of the practical algorithms for evaluating JAK2 unmutated erythrocytosis. So you have increased hemoglobin or hematocrit more than the cutoffs, like 16.5 or 16 in females. And you further, of course, you will want to rule out the JAK2 mutations further. And this JAK2, as I described, is not JAK2 V617 only, the other JAK2 mutations as well. So slightly broader panel helping you evaluate the other JAK2 mutations. One, this has been done. The next key investigation is the serum erythropoietin measurement, along with various history and what stage this is presenting. So serum erythropoietin levels along with the history kind of helps you evaluate this further. So in a cases where there is long-standing history, long-standing duration, and a family history, and the erythropoietin is subnormal or decreased, so you consider the EPOR mutations. So they are kind of one of the commonest in this workflow. And if they are negative, then you evaluate further using NGS and rule out other mutations. If the EPO levels are normal or increased, then you want to evaluate further for high oxygen affinity hemoglobin variants or HOAV, and you would like to do various tests like the venous P50 determination, capillary electrophoresis, HPLC, mass spectrometry, or the beta globin gene sequencing. So you could start with some of these in investigations. So you have a JAK2 negative erythropoiesis, long standing with family history, you have normal or increased EPO levels, then you want to evaluate for the using capillary electrophoresis HPLC, and you want to rule out high oxygen affinity values. And if those P50 is less than 24, so usually 24 to 28 is what this values are. So if this P50 is less than 24, so you consider mutations in these particular genes. So this is 2,3 biphosphorate deficiency, piezo1 mutations, and methemoglobinemia. And if the P50 is more than 24, then you consider the various other germline mutations, which includes the VHL, which is very commonest type of mutation in the oxygen sensing pathway, as I shared earlier. And this is known as Chuash polycythemia, where the erythropoietin levels are high. And also the mutations in other three genes that I mentioned, the HIF2A, PHD2 levels. And here the erythropoietin levels are often normal as well. And if you are not able to get the mutations in this, then you need to consider other mutations in HFE gene, where the ferritins could be high, and SLC30A10 mutations. These specific mutations are associated with hypermagnesemia, Parkinsonism, and cirrhosis. So these are some of the mutations in these pathways as well. So in the arm where you have acquired or unknown duration, when you don't know that, again, erythropoietin helps you guide guide it further. So if the erythropoietin levels are increased, you know that this could be because of some erythropoietin producing tumors. And I shared some of the tumors which could be associated with this increased erythropoietin. It includes RCC, hepatocellular carcinoma, cerebral hemangioblastoma, meningioma, pheochromocytomas, uterine leiomyoma, parathyroid adenomas or carcinomas, cases of renal artery stenosis, renal cyst, even post-transplant erythrocytosis is also there. And when you have compensated or increased erythropoietin, you could have cardiopulmonary disease, the obstructive sleep apnea, carbon monoxide poisoning, smoking, Cushing disease, drug-induced or relative erythrocytosis could be there. And there are various drugs which have kind of been implicated in causing this erythrocytosis. So history of drug use or some of these conditions can be very helpful in figuring out whether this is due to drugs or some other reasons. And even then there are other mutations also described, LNK mutations, where the EPO levels are decreased. And I described Tempe syndrome or Poem syndrome in particularly in the plasma cell neoplasms situation. So this is a practical algorithm for JAK2 mutated erythrocytosis being described. There are still cases where you may not be able to find figure out what is the particular diagnosis, or narrow down to the diagnosis. You can have certain scenarios. So now I'll take you some of the studies. So this is some of the so these are now Europe's largest idiopathic erythrocytosis database. So cases of hereditary erythrocytosis. So around 909 French patients, cases with a median age of 50 and 86% males were sequenced using an NGS panel. This is around 9 years patients who were sequenced. And of this 909 patients of hereditary erythrocytosis evaluated, the diagnostic yield was only 7.9% of the cases, where using an NGS panel, we were able to diagnose that what is the mutation, particular mutation, or what subtype of was there. Only 8%. And the key genes implicated here included EPAS gene, EGL1 gene. This is oxygen sensitive pathway, SH2B3, germline SH2B3 mutations, the hemoglobin, beta globin, and alpha globin gene variants. There were cases of JAK2 mutations, and we have to be very careful when we say JAK2 negative. I have been highlighting again, time and again, that JAK2 doesn't mean only V617. There are additional JAK2, and even if, and how you are evaluating your JAK2 is also very important. Either an NGS or a high sensitive real time PCR are the two techniques which allows you to be able to go down to the sensitivity of 1 to 2%, and that has been some of the recommendations. And using less sensitive techniques to screen them may lead to false negative things, and this probably has happened here. So sorry, am I audible?
You were not audible for a while.
Oh,
Now you are audible.
sorry. Just I will go back. Can I go back a minute?
This is the slide you are on.
So here I was not audible from here.
Yeah, after this.
Okay. So I was trying to share that the largest study with respect to the hereditary erythrocytosis. So this is the Europe's largest idiopathic hereditary database. So around 909 French patients were screened during a 9-year-old study, and the diagnostic yield was only 7.9%. So only 72 patients of the 909 hereditary erythrocytosis screened we were able to diagnose with certainty the type of genes mutations present in these cases. So the commonest among them were the EPAS1 gene, the EGL1. This is the oxygen sensitizing pathway genes, SH2B3, the congenital germline mutations in SH2B3 genes, then beta globin and alpha globin genes. There were cases of JAK2 mutations which probably could have been missed. And I mentioned earlier as well that when you say JAK2 negative, it is not just JAK2 V617F. Additional JAK2 mutations in exon 12 and other genes are also needs to be excluded. And also the screening for the JAK2 has to be by a sensitive assay, which allows you to pick up around 1 to 2% WAF as well. And NGS and real-time PCR are two sensitive techniques to be able to pick up these JAK2 mutations. So while doing your JAK2, we need to be sure that the assay is sensitive enough to go down to 1 to 2% levels. Otherwise, you can have cases where false negative cases of JAK2. And the other genes being the EPOR gene, PIZO1 mutations, VHL, and BPGN1. So the in this largest database of hereditary erythrocytosis, only 8% cases could be diagnosed with certainty. And also it was important to note that this positivity was more in the younger age group. So in less than 20, almost 20% of the cases mutations were diagnosed, as opposed to more than 60 year, where the percentage positivity was less. So more in the younger age group and less in the elderly age group or more age group. some problem in this slide. I'm not able to move. I will reshare the slides. Not able to move that slide. I think slides are not moving. Some issue. So now, with respect to the Indian scenario, so this is one study done from PGI Chandigarh where they tried to evaluate the genetic basis of unexplained erythrocytosis in Indian patient, and of the 18 patients screened, 18 patients screened from 15 families, 73% of the families they were able to detect mutations, and primarily this was VHL, homozygous VHL mutation, that is HB2-wash polycythemia. So unexplained erythrocytosis in 15 families screened by Sanger sequencing of the only 4-5 genes, the EPOR, exon 8, VHL, ELG1, and HB and hemoglobin B and hemoglobin. So very few genes, and primarily there the HB2-wash was the polycythemia was the commonest mutation, and subsequently using a low Singer RFLP, so same VHL, because they had got the VHL mutation. So further 99 JAK2 negative V617 cases were screened for using a single cheap PCR RFLP technique, and they were able to detect VHL gene mutations in around 8% of these cases. So less number of percentage of cases as opposed to the earlier where they were able to see that almost 50% of the cases had VHL gene mutation. So just few studies to show that so nowadays traditionally how this approach is going is that you want to screen by JAK2, and when you are screening for JAK2, either single gene or using an NGS, so particularly in the myeloid panel is what you are trying to evaluate, and once that is negative, you now want to go in further for some additional testing, and these are some of the tests which have been available worldwide. I try to concise them. So these are at various places how people are trying to evaluate erythrocytosis further once JAK2 is negative. And some at places VHL gene, 3 gene, 4 gene, 8 genes, 40 gene, 15 genes. Some of the genes known to be associated with erythrocytosis being evaluated further. And these are some of the panels which are available. And if I try to consolidate that the list of genes, so we come to around 21 genes commonly described, where and this is some of the genes primarily in the oxygen sensitive erythrocytosis. So you have a list of 21 genes which now screen, and traditionally now what I have seen people doing is once the myeloid is negative, you want to screen for erythrocytosis further. You either use a panel or a single gene, 2 gene, 5 gene, or you do an exome sequencing. So you have different 2 ways to approach that. And this was the problem that was discussed by my colleagues, as I was mentioning earlier. So you have to screen them, two of them separately, and you don't know which is coming what, and that is the initiation of the panel that we are trying to do now. So what we are trying to do is we have a germline mutation. So this is being done at Unipath now, that we have around a list of 35-40 genes that I mentioned. We kind of has been described in the literature in various places, and we try to combine the somatic variants, particularly the JAK2, V617F, and other JAK2 mutations, CALR, MPL mutations in terms of somatic. They're also tested by an NGS, but additional somatic testing is also done. And then you test out for 35 genes implicated in the erythrocytosis. So this approach is what we have started doing, and this has been after discussion with some of my colleagues. So I will just share that some of the cases through that approach. I'll just check whether I'm able to share again. Yeah. So this is case one. This was a 14-year-old male presenting with a long-standing history of erythrocytosis. HB levels were 21, with normal WBC and platelet, no consanguinity, no smoking or alcohol use, because smoking, alcohol, stress has also been associated with erythrocytosis. And many patients, you find that there is family history of erythrocytosis in the father. So there is family history. The EPO levels are normal. And considering the young onset with family history, the erythrocytosis panel was done. And so here the EPO levels were normal. So you consider this whole axis when you want to do the oxygen saturation, and you want to evaluate and then rule out the HOAVs here. But I don't see anybody using this. So probably from the erythropoietin level, next is myeloid, and this next, the third is either germline. So this is practically coming down to germline or the mutation testing further. So in this particular case, the NGS erythrocytosis panel, which includes somatic mutations and the germline mutations, was done. And the somatic, all of them were all negative. And with respect to the NGS panel, the 40 gene mutations, we got a homozygous mutation in the VHL gene. So this is a missense VHL pathogenic variant. This is the R200V mutation. This is autosomal recessive in nature. So this is also known as I described earlier, the HB-Chuash polycythemia. This is a VHL homozygous gene mutation and autosomal recessive in nature. So this has been described, and the erythropoietin levels in these range from normal to high. And the mechanism here is the, as I think earlier showed, that VHL gene mutations, the defective pathway is there. So this axis, this VHL, HIF, PHL2 is defective, and the VHL is not able to cut that, and this complex leads to increased or unregulated HIF levels, leading to the erythrocytosis. So this is the mechanism particularly associated with these type of polycythemias. So case 2 is a 16-year-old male from Eastern India presenting with erythrocytosis. His hemoglobin level is 17.9 with normal WBC and platelets. The erythropoietin levels are 9, and again repeated after some time. After 2-3 months, the hemoglobin levels are high, hematocrit is high, RBC levels is high, 6, and with normal WBCs and platelet counts, erythropoietin levels are again normal, and there is no family history, no consanguineous marriage. And then this erythrocytosis panel is done further. The somatic thing, JAK2, CALR, MPL are negative, and within the NGS erythrocytosis panel, you have the PIZO1 mutation. So as I had described in the workflow, when you have the normal EPO levels, you need to look at there could be PIZO1, 2, 3 BPG and other mutations, and these PIZO1 mutations have been associated with dehydrated stomatocytosis, dehydrated somatism. This is just to show that this is a nonsense heterozygous variant. This is autosomal dominant in nature, leading to the dehydrated stomatocytosis. And patients with these may have uh, peripheral blood spherocytes as opposed to stomatocytes, because they have different morphology, and because of the water loss and shape changes in this cases, these particular cases are may have spherocytes or stomatocytes in the recognition. And one more important part is that these cases are at a risk of major post splenectomy thrombosis. So no splenectomy should be done in these cases, as opposed to the spherocytosis where you might want to do it. But in this particular type of no splenectomy is done, because splenectomy causes thrombosis. So with respect to the piezo mutations, this gain of function mutation, these piezo ones are present in many places, and they kind of affect the erythroid maturation or RBC membrane, and also affecting the erythrophagocytosis, hyperferritinemia. So wherever the piezo one is present, it may be involved and may be implicated through this erythrocytosis pathway. So that is these mutations, and whatever some of the symptoms or some of the things that you see are because of the presence of piezo1 at various places. So third case, this is a 41-year-old female presenting from Western India with erythrocytosis, known case of ovarian cyst, having HB of 17.6, and serum erythropoietin is normal, 17.8. And she has a history of restrictive lung disease. Chest X-ray is normal, 2D echo is normal, USG normal. There is a ovarian cyst, and she had phlebotomy twice due to this hyperviscosity, and subsequently now you want to evaluate further, and this panel is done. And a 41-year-old female with cyst, so your somatic mutations are negative, and you get a mutation in the this EGL1 gene. So this EGL1 gene is an oxidizing in the oxygen sensitive pathway. This is a deletion, very uncommon to pick up deletions, but this deletions, it is a pathogenic deletion which is from the exon 3 to 5. So 3, 4 exons are deleted, deleting the critical functional domain, affecting the proxyl hydroxylase domain, PHD2, again in the same axis. So we have seen VHL, then PHD2 genes leading to large deletions, leading to the the impaired hydroxylation and degradation of this pathway, leading to the erythrocytosis. And this is one large study, one of the largest study where they implicated this PHD2 or the EGL1 gene variants in erythrocytosis. They sequenced around 2,000 patients, and of those 2,000 patients in 10 diagnostic centers, they identified 39 variants. Many of them were VUS. So finding VUS is not a major issue here, because you are in the same pathway. You are able to pick up this variant. So based on this study, now we know that these variants have a relationship to the erythrocytosis, because sometimes these VUS variants can be classified as pathogenic as we go along. So case 4, so this was a 29-year-old male from Eastern India presenting with erythrocytosis. They had echogenic pruritus and headache, and there was a resident of coal mine, and no smoking, and hemoglobin levels were 18.2, PCV was 52.3. The WBC and platelets was normal. The patient had fatty liver. Other vitals were normal, and erythrocytosis gene panel was done. So since this panel has the somatic, all those somatic variants were normal. And you had the mutation in the CYBR. So it was a compound heterozygous mutations in CYBR3 genes. So now both of them were VUS earlier. So these were VUS mutations, and this is described as an autosomal recessive and associated with methemoglobinemia. Subsequently, within 1 year, 2 years, these were classified. We did a reanalysis, and these now variants were likely pathogenic. So that is what I was mentioning. So finding VUS in some of these genes and subsequent on reanalysis, they could be pathogenic. So documenting even the VUS in a particular scenario is also important. So in this particular scenario, this was a methemoglobinemia, compound heterozygous head chain methemoglobinemia, which is a disorder of NADPH5 reductase deficiency. It is an autosomal recessive disorder characterized by decreased oxygen carrying capacity and resulting in hypoxia and other symptoms that we see. Another case, this is case 5. This is a 30-year-old male presenting with polycythemia. HPLC was normal and was hereditary causes need to be ruled out. So now, up till now, I had been showing the approach of the erythrocytosis panel. Sometimes they can also be directly come to you with the exome approach as well. So here these were negative, and what we got was a mutation in the PKLR gene, and this is a heterozygous autosomal dominant pathogenic variation leading to increased ATP levels of the erythrocyte, leading to the erythrocytosis. So this is a very rare cause of erythrocytosis, and this is leading to abnormal red cell metabolism. So this was another case. So this last case, this is a 24-year-old male presenting with heavy headedness, giddiness, polycythemia, high BP. EPO levels were decreased, bone marrow trilineage hematopoiesis, and MPN panel was negative. Now exome or a clinical exome was being done to rule out any causes of hereditary causes of the polycythemia. So that was the call here, and surprisingly, we got a mutation in the CLCN2 gene. Now this is, so we have not got anything that I described earlier. So this is apart from normal JAK2 negative erythrocytosis, something different. So this gene mutation is associated with hyperaldosteronism. So this is a secondary erythrocytosis due to autosomal dominant mutation. So just wanted to show that many things we don't know. We know what we are able to characterize them, but there are things which can still fall outside the domain. And this is just another case where we were able to pick up cause of hyperaldosteronism, familial hyperaldosteronism, leading to the secondary erythrocytosis. And this is known to have erythrocytosis as well. So now, since we have started doing this panel or testing specifically focused on erythrocytosis, and this has been thanks to my colleagues who've been kind of bringing this queries or issues, and we kind of more focus on that area. We've done around 202 cases, 205 cases, and with of erythrocytosis, where you predominantly males, median age 39 years. 156 have been negative. We have not been able to pick up any mutations. We have been able to pick up pathogenic mutations in 22 of the 200 cases, almost 11% of those cases. And these 22 cases include somatic JAK2, 1 CALR mutation, and germline, 9 germline. So almost 4.5% of the cases, germline variants are there. And I've shared few of those cases. There have been 24 VUS cases as well. Among these 9 cases, you have 4 out of 8 were disease causing, 2 autosomal dominant, 2 autosomal recessive, 5 were carriers. And these are some of the mutations like JAK2, beta globin gene, TET2, VHL. I showed one of the homozygous CHOASH variant, PIZO1, I shared PK as a CALR mutation. So these are some of the pathogenic variations apart from the JAK2 mutations that we saw. In terms of VUS, these are some of the VUS genes, piezo being the commonest mutation, then SH2B3, TET2, ACO1, EGLN1, the EPAS, EPOR, and GF1B2 genes. So these are 24 cases of VUS that we have been able to see that. Now, so till now, erythrocytosis, germline mutation, EPOR mutation, and various other somatic mutations as well. So now, very recently, I came across, this is 2026 paper, where they describe even somatic EPOR mutation in primary erythrocytosis. So up till now, whenever you are evaluating JAK2 negative erythrocytosis, the erythropoietin levels are done, it is low. And then first thing is that whether it is a germline EPOR mutation. But in this particular scenario, this is not germline, this is somatic EPOR mutation leading to erythrocytosis. This has been a very recent finding and very good to know that you can pick up somatic EPOR mutations in a 60-year-old female non-smoker with a hemoglobin levels of 18.3 and RBCs of 5.5. And this particular variant, which has been described in the EPOR, had a VAF level of 5.8% only. There have been other mutations which have been described, but this is primarily germline and no somatic EPOR mutations have been described. So this was the first description of somatic EPOR mutation at a VAF of 5.8%, leading to explainable erythrocytosis in this particular case. So now last few slides that we know now we are trying to figure out a lot of things why we want to get the correct diagnosis. Of course, we want to prevent any unnecessarily investigations, unnecessarily phlebotomies, and we want to distinguish and manage them in the proper way. We want to distinguish them from polycythemia and picking up germline variants and guiding family and for genetic counseling and managing symptoms and preventing the thromboembolic events in the correct way. So that is why you want to diagnose them in the correct way and then guide patient therapy in a better way. Now, few specific management decisions based on the genetic subtype. So that we have been trying to figure out where genetic mutations could guide specific management, and these are some of the things where like for VHL mutation, the homozygous, the risk of thrombosis is there even with mild hematocrit elevation. So there is a high risk of thrombosis. EPOR mutations, they good response to phlebotomy. So if you are an EPOR mutated, the response to phlebotomy is good. For this VHL, there is an higher risk for pulmonary hypertension. The mutations in the EGL1, PHD2 mutation, there is a cancer malignancy, developing malignancy is higher in these patients. In HIF2 mutations, in the gain of function mutation, there is a risk of paraganglioma. So screening or additional testing might be helpful for them. The HIF2A, they need periodic abdominal MRI. As I was mentioning, for this Chuash polycythemia, they have a lower threshold for phlebotomy at less than 45%, and they have increased risk of cerebral vascular events. So diagnosing them correctly and having the data to be able to know what cutoffs and what additional risk or additional mutations could lead to. So that is very helpful to know the specific type of management in that. So with that, I would like to end here with few take-home messages that this JAK2 negative erythrocytosis is not a single disease. It is a very heterogeneous disease, and it does not mean that we do not have a cause and everything is benign. We need to evaluate them further. We need to find a cause. At the moment, 5 to 10% of the cases is where you are able to figure out a cause. And erythropoietin, serum erythropoietin is one of the most valuable tests, and low EPO levels kind of guide you further towards knowing that whether there is a germline EPOR mutations or not, and additional testing for high affinity hemoglobins, the oxygen sensitive pathways, HIF pathways, the VHL gene, they are usually underdiagnosed, and we need to evaluate them carefully to be able to diagnose and then manage those cases with confidence. So with that, I would like to end here and thank my colleagues, specifically Dr. Firoz, Dr. Ekta, for helping me put through this topic. This has not been an easy topic for me to prepare. And also, I would like to thank Dr. Varun Bafna and Dr. Priyanka Samal for those valuable discussions. So that, we are trying to work more in this area. Going forward, the idea is to be able to combine the whole myeloid and these erythrocytosis genes, so that in the one go we are able to have all the information available. So thank you so much, and I'll be happy to take any questions.
Thank you, Neeraj. Very beautifully discussed about the etiology and how the genetic studies are useful. As we are a bit running behind the schedule, I request you to answer two questions put up in the chat box by answering in the chat box, as we will be moving on to the next webinar, which is scheduled at 7:30. So thank you once again. Extremely grateful to you for doing this.
Thank you so much, sir.
I'll just share my screen to introduce the next speaker, which is Dr. Nitin Sood from Gurugram. We all know Dr. Nitin Sood, but just to complete the formality, he's Senior Director, Clinical Hematology and Stem Cell Transplant, Medanta Medicity, Gurugram. He is a hematologist with over 20 years of experience. He was awarded a bursary in 2011 by UK Myeloma Forum, American Society of Hematology, and first prize by British Society of Hematology 2009. He is a member of the General Medicine Council UK, Royal College of Physicians London, Royal College of Physicians Edinburgh, Royal College of Pathologists Hemato-Oncology UK, and has membership of the Royal College of Surgeons MRCS. He completed his MBBS from Government Medical College and then followed MD General Medicine from Delhi University, DNB General Medicine from National Board of Examination, FRC Pathology from Royal College of Pathologists. His clinical interests include hemato-oncology, hematology, hemostasis, and thrombosis. Summary of his education is FRCP 2008, Royal College of Pathology, UK, MRCP 2005, Royal College of Physicians, UK, MD 2002, Delhi University, DNB 2002, National Board of Exams, MBBS 1996, Mysore University. He's going to today speak to us from evidence to excellence, integrating Zanu into practice. I'll stop here, request him to take over.
Good evening, sir. Thank you very much for that introduction. I'm trying to share my slides. If somebody can say if that worked.
Yeah, we can see the slide.
Perfect, sir. Thank you. Right, I'll just put it in full screen. Yeah. So it's about, it's a sponsored session. As you know, it's from evidence to excellence. So Glenmark wanted to present data on Zanubrutinib, putting Zanubrutinib into clinical practice. And as we know, Zanubrutinib is a BTK inhibitor. And the question is really in CLL and other lymphoproliferative disorders, why do we need a new BTK inhibitor? And partly the answer is because of the toxicity of the previous BTK inhibitors. Now, we know the BTK inhibitor journey started a long time ago with ibrutinib, but ibrutinib demonstrated a broad range of BTK inhibition. It also has active metabolites, and because of its off-target effects, ibrutinib does a lot of atrial fibrillation and cardiac toxicity. We see bleeding and bruising events, which are quite common, and sometimes also get rash, joint pain, and diarrhea. So, the adverse events in real life will lead to a lot of discontinuation, and there was a lot of discussion in the past about this. And then subsequently, we got acalabrutinib and now zanubrutinib. And that's why we need new, more selective BTK inhibitors. And in comes Zanubrutinib because it's a selective BTK inhibitor. It has less off-target effects. It works by inhibiting the downstream signaling. This is where it works and causes a halt in B cell proliferative activity. So this diagram shows how various BTK inhibitors do off-target effects. And as you can see, the BTK is the blue one, and the red ones are the red little dots are off-target kinases. And so the less reds you have, the better it is. And Zanubrutinib has the least, which is why it becomes an ideal alternative for when we need less toxicity, especially in patients who have polypharmacy, patients who have comorbidities, who will be affected by off-target effects. The less off-target effects you have, the better it is. The other advantages it provides is there is no dose adjustments with common drugs, especially polypharmacy, and there is no effect with food. The dosing schedule is flexible, so you can have people who have twice a day medicines, they can take it twice a day. People who prefer once a day and get it over with can have once a day. So the dosing is quite flexible in that sense. And from a hepatic impairment point of view, the plasma protein binding of Zanubrutinib in patients with hepatic impairment was similar, so very little effect on that. The good thing is Zanubrutinib has a lot of approved indications, so CLL across the board, depending on whether, irrespective of whether you have the mutations. Waldenstrom's, you can have it upfront. Relapsed mantle cell, you can have it if you have comorbidities. You have it in marginal zone lymphoma in patients who have received at least one anti-CD20 based regimen. So basically failed anti-CD20, and in later lines in follicular lymphoma. And I'm going to show you a few trials on each one of these indications so that we know how we arrived at these indications. So here's the clinical evidence, and CLL being the first one because that's the poster child for BTK inhibition. The Alpine trial was the one that brought Zanubrutinib versus Ibrutinib, and it brought in Zanubrutinib on the main stage because it was tested in relapsed refractory CLL and SLLs. I like Alpine because it not only shows non-inferiority, but also potentially has superiority over the other inhibitor, the other BTK inhibitor, which is Ibrutinib. So Ibrutinib used to be the standard of care then. So the patients were screened and they were randomized 1:1 in either Zanubrutinib, which was arm A, 100 in the standard dose of Zanubrutinib, which is 160 milligrams twice a day, versus Ibrutinib, which is 420 once a day. So the reason why Zanubrutinib was compared to Ibrutinib is because we were having so many real-life discontinuations of Ibrutinib, and a more selective BTK inhibitor looked very attractive at that point. It was designed as a non-inferiority trial, and superiority was assessed by the independent investigators. So this is what it showed, that not only was it non-inferior, it was superior to Ibrutinib. And the top red line is Zanubrutinib, where the 36 months progression-free survival is 65% compared to 54. So the relative risk reduction in disease progression or death is reduced. And it's reduced, and it's even more impressive in the high-risk group, which is the 17p group or TP53 mutated. So not only did it work, it also showed the 6-year long-term results, which shows that it continues to work even after 6 years. Now, this is the 6-year follow-up, and these are the side effects, which are the cumulative side effects. And as you see, as you go on from 0 to 1 to 1 to 2, and up to 5 to 6 years, the side effects remain relatively stable. The blue bar is the Zanubrutinib bar. we can see that I mean, the hemorrhages are less. The major hemorrhages are less. The hypertension is less. The cardiac events are less. The neutropenia is slightly more, but that didn't translate into more infections. So then, when Zanubrutinib is trying to move into first line and has moved into first line, and Secure trial is the one that did that. And Secure tested Zanubrutinib versus bendamustine rituximab in previously untreated. So first line treatment. And the good thing was that not only did they test it versus bendamustine rituximab, but they also risk stratified or pre-trial stratification into the without 17p cohort and the with 17p cohort. And they made 3 cohorts with 4 arms. So cohort 1 was the patients who had without 17p and could either receive zanubrutinib or bendamustine rituximab, which used to be the standard of care in those days. The cohort 2 was with 17p, where you could get zanubrutinib, and the cohort 3 was the all oral combination in upfront CLL, which is the most exciting one, although still not approved, zanubrutinib venetoclax combination. So the primary endpoint was progression-free survival by an independent review committee in cohort 1, and then there were several key secondary endpoints which we're going to discuss. So this is where the BTK inhibition really scores above bendamustine rituximab. There's definitely a superior progression-free survival versus bendamustine rituximab. So this is the trial that really brought an end to chemoimmunotherapy for CLL, even upfront CLL. And this data is in patients without deletion 17p. So the first cohort, where they were randomized between zanubrutinib and bendamustine rituximab. So it didn't matter whether you had the IGVH mutation or not. Zanubrutinib with the mutation, without the mutation, did better than BR with or without the mutation. So the 4 curves, the top one is zanubrutinib with the mutation. The second one is without the mutation, and so on. But both the top curves doing better than both the bottom curves. So this is the progression-free survival. And this is in the deletion 17p cohort. So remember, this is the second cohort where they just got a zanubrutinib on its own. And a difficult population to treat. But despite that, the overall response rate was 97.3%. So that's very impressive. Not only that, median overall survival was not reached. And the estimated 60-month overall survival was 85%. So very impressive results with this drug, and shows that the drug is very potent. Also in cohort 2, progression-free benefit was seen irrespective of IGVH mutation. So both lines almost merging with each other. So it didn't matter whether you had the IGVH mutated or unmutated, the drug was going to do as well for you. And finally, and I must stress this, that zanubrutinib venetoclax arm is not approved at the moment. But this is the arm D, where the 17p mutated patients were offered venetoclax zanubrutinib in the clinical trial. And this is what it led to. So 87%, 36-month survival. And again, it didn't matter whether you had the mutated IGVH or the unmutated. As long as you got the combination, you tended to do very well. So 36 months, 87, 88% survival. Now, real-world studies are very good to check the trends of treatment, but real-world and real-world patients mirror our patients much more closely than the clinical trial patients do, because clinical trial patients are highly selected. And the only problem with real-world study is that it cannot sort of match the phase 3 trials in terms of evidence they generate. So real-world studies have their own benefits. And in the real world, zanubrutinib was doing better than acalabrutinib. So both monotherapies in time to next treatment and overall survival. So the blue line is zanubrutinib, followed by the orange line, which is acalabrutinib. And you can see the lines have started to separate, and they continue to separate up to 30 months. So this data needs to mature further, but it's already showing a trend towards improvement early on. These are real-world outcomes among the Medicare beneficiaries treated with first-line BTK inhibitors for CLL. And this is a retrospective observational cohort, which is where the limitation comes in. But the outcomes included in patients who had CLL, who were older, and who started first-line BTK inhibition between January 2020 and September 25. So a more recent population, and you can see Zanubrutinib doing better than acalabrutinib and ibrutinib. So all three curves are separating out. Remember, this is not randomized. This is real-world data, so there might be some bias in it. So again, not only did they do better, their time to next treatment excuse me, was longer compared to the other two BTK inhibitors. That did translate into better overall survival. So again, the lines are separating, and they continue to separate up to 4 years after the data was collected. So what about other indications? I mean, there are 4 other indications, and Waldenstrom's macroglobulinemia being one of the major ones. So then the Aspen trial compared Zanubrutinib versus ibrutinib monotherapy in patients with Waldenstrom's. Remember, Waldenstrom's can be subclassified into patients who have the CXCR4 mutation status and the MYD88 mutation patients. So the cohort 1 was the one who had CSCXR mutated, and they were further stratified into number of prior lines of therapy. And so they either got Zanubrutinib or ibrutinib, and the cohort 2, the ones with MID88 patients were given Zanubrutinib as monotherapy. So they were treated until there was an acceptable toxicity or disease progression, and their safety and survival was noted. So we can see higher rates of CR and very good partial response. So complete responses and very good partial responses were better with Zanubrutinib versus ibrutinib. And these are stratified by CSCR4 mutated in the first subgroup, followed by the unmutated, and of course the MYD8 mutated. So there were consistent responses were seen with Zanubrutinib regardless of line of therapy in various cohorts, and especially in cohort 1. So there is the safety issue, and Alpine and Aspen trial data was combined to look at Zanubrutinib versus ibrutinib safety. And as I said in the previous safety slide discussion also, the infections were less with Zanubrutinib, although febrile neutropenia was slightly more. But the incidences of hemorrhage, thrombocytopenia, secondary malignancies, and anemia was less, although neutropenia was slightly more, but that didn't translate into the infections, which was less with Zanubrutinib. So these are the overall safety and most common adverse event data, and Zanubrutinib tends to score better than other BTK inhibitor, which is not surprising because it's one of the more selective ones. These are the updated safety and efficacy results of Zanubrutinib in patients with B-cell malignancies who are intolerant of ibrutinib and acalabrutinib. So this is the study that gives us confidence in the fact that if you're intolerant or unable to tolerate one BTK inhibitor, doesn't mean you won't tolerate all of them. So the more selective ones are still tolerable. And so the ones who were intolerant to ibrutinib were cohort 1, intolerant to acalabrutinib alone or acalabrutinib and ibrutinib were cohort 2, and they were all put into the Zanubrutinib arm. And the primary endpoint was investigator-assessed recurrence and change in severity of ibrutinib or acalabrutinib intolerance events. So the severity was measured according to the standard measuring criteria, and there were several key secondary endpoints. So the pie chart on the right shows the total intolerance events The big blue bar shows that the ones that where the intolerance did not occur, and the green one is it recurred, but it recurred at a lower grade than the original drug. So if you see combined both of them, 90% where the intolerance or the drug was tolerated better than the previous drug. So which means that if you're not able to tolerate one of the drugs, you can easily shift to zanubrutinib and get better tolerance. So here the tolerance is stratified by the events. Again, the blue bar shows did not occur and the green one shows at a lower grade. Finally, the last indication is follicular lymphoma. And follicular lymphoma is used for later lines of therapy because we've got lots of therapies for follicular lymphoma. And Rosewood was the trial that brought it in. And it was zanubrutinib plus obinutuzumab in follicular lymphoma. Since it was a phase 2 trial, all patients got it. And this was at least for patients who failed more than or equal to 2 prior lines of therapy. So at least 2 lines of therapy um, uh, with rituximab being refractory. So you could either have zanubrutinib with obinutuzumab or obinutuzumab by itself. And the primary endpoint was overall response rates as by a blinded committee and several secondary endpoints. So disease responses by the independent review committee saw that there were almost 42% CRs. Remember, this is a population where they've already had more than 2 lines of therapy, so at least 2 lines of therapy. 42% with the obinutuzumab arm got a CR and 28% got a partial response. So overall response rates almost 2/3 of the patients. Although with obinutuzumab itself, it was less than half of patients. So the combination really works. And it can be a useful tool in our armamentarium to treat follicular lymphomas in later lines of therapy. So progression-free survival, as per the independent review committee, was longer in the ZO arm or the obinutuzumab arm. And finally, mantle cell lymphoma. So mantle cell lymphoma, second line, BTK inhibitors are pretty much standard, but the question really was whether you could use zanubrutinib. So it was a single arm zanubrutinib in relapsed refractory mantle cells. And the study design, I'll just show you this. So the study design was all patients with relapsed refractory mantle got the drug, and the median follow-up was about 3 years. You got an overall response rate of almost 84% with CRs of 78%. So median duration of response was not reached and was a well-tolerated drug. These are the efficacy outcomes by subgroups. So needless to say that even every subgroup saw a benefit with zanubrutinib. And the marginal zone lymphomas, again, don't have many treatment options, which means zanubrutinib monotherapy in relapsed refractory marginal zone lymphomas after they've had bendamustine rituximab or rituximab on its own can be a very useful drug to use in these patients. So relapsed refractory who received at least 1 prior line of therapy, which included a CD20 antibody, could get zanubrutinib at the standard dose, and the primary endpoint was overall response rate assessed by an independent review committee with, again, ORR, PFS, OS, or duration of response being secondary endpoints. So as usual with BTK inhibitors, treatment was continued until unacceptable toxicity or loss of response. So these are the response and event-free rates. And you could see best overall response was found in all sorts of lymphomas. Extranodal did the best with 40% CRs, but the ORs were quite high. 64% in extranodals, 76 in nodals, splenic 67, where the category was unknown was about 50%, and totaled about 2/3 of patients who were given the drug tended to respond. So what do the guidelines say? I mean, given all this data, we have a wide range of indications for this BTK inhibitor. We'll start with CLL. It's first line and category 1 preferred in patients without 17p. Although without 17p, unmutated, mutated IGH, we have many other combinations which are available. But with 17p as a second line, is the preferred drug. But we also prefer BTK inhibitors in patients who do have 17p because that's where the best response is, or um, the best use of a BTK inhibitor is. It's a preferred second line and subsequent therapy for mantle cell. Waldenstrom's, it's category 1 preferred treatment option for frontline and previously treated Waldenstrom's. It's a preferred recommendation for second line and subsequent in marginal zone lymphomas, where patients, as we've seen, have failed anti-CD20 based therapy and bendamustine. And in follicular lymphoma, it's more than 2 lines of therapy. So as an option for third line of therapy. So that's where the drug is positioned. So to summarize, these are the take-home messages that it's a next-generation BTK inhibitor. It's highly potent, highly selective. We know it works better. It has less side effects. There's low off-target binding, leading to less cardiac morbidity and less bleeding, bruising events. And it's superior to other BTK inhibitors. If you look at the original data, it does progression-free survival-wise, it does better. So it's a more potent drug, and its labeled indications are CLL, mantle cell, marginal zone, Waldenstrom, and follicular. So it's a useful drug to have. With that, thank you for your attention, and I'm quite happy to answer questions at the end.
Thank you, Nitin, for that wonderful presentation and educating us with this wonderful BTKi Zanu, which is the new kid on the block for us, and bringing out very important features with respect to its superior efficacy and safety than the previous generation BTKis. And as we saw that there are a large number of B-cell chronic lymphoproliferative disorders with CLL as the leader and all others to follow, where its efficacy has been shown and its safety has also been shown. So I will request Dr. Nitinjun to join the panel discussion, which will be an open forum so that we can all interact with each other. May I request, yeah, so my screen is here. Thank you. So this panel discussion has also been named as From Evidence to Excellence, Integrating Zanu into Practice. I'll be moderating it. And as I said, though we have certain panelists here, the list I will show you soon, but all of you are welcome to participate. So these are the official panelists: Dr. Kinjal Shah from Hyderabad, Dr. Manoj Toshniwal from Sambhajinagar. They are both there. Dr. Mukesh Desai from Mumbai, but I don't see him. Dr. Nivedita Dingra, Ghaziabad, UP, again I don't see. Dr. Pooja Prasad from Chandigarh, which is there. And Dr. Tribikram Panda from Bhubaneswar. But please, all of you, please interact. It's an open forum totally. And Nitin Sood, as I said, is invited to join us in the discussion and answering the questions. As Nitin brought out, so we have 3 molecules in the field of BTKi. The oldest, Ibrutinib, then came Acala, and then came Zanu. If I summarize this talk in one statement, say for the UGs and the PGs, then Ibru was the least effective and the most toxic. Acala was shown to be equally effective. Until today, there is no data to show that Acala is superior in the efficacy to Ibru, but it was safer. So it sort of replaced Ibru because of its safety. And then came Zanu, which was even safer than Acala, and on top of that, it had superior efficacy. So this is where the Zanu stands. It's superior in its efficacy, irrespective of the type of disease you're talking of, and it is safer than both Ibru and Acala, while Acala is equal in its efficacy to Ibru, but safer. So as Nitin brought out, that Zanu trial started when Acala wasn't there. So your comparative arm was invariably Ibru. But as we know that Acala is safety is superior, but efficacy is similar. So if Zanu is superior to Ibru, it automatically becomes superior to Acala. Now this is the timeline as was discussed. You concentrate on the Ibru, almost 1.5 decade. Then you have Acala, almost about 7 years ago. You have Zanu, it's about 3 years ago. So it's really a new kid on the block, and especially for us because it's available only for last few months. So we begin with the very first question. And I think that's an important question because that gives you the basis for why Zanu is more efficacious and more safe. So what structural differences differentiate Zanu from the first generation BTK inhibitor, or I would say even Acala, which is a second generation BTK? So what are the structural differences? I will put on one slide and I'll ask our panelists and others to give their opinion. Kinjal or Manoj, you want to take up this one?
Hello, sir. Good evening. Kinjal here. So, yes, this Zanubrutinib, structurally, it is highly selective, specifically for the BTK inhibitors, and the affinity to bind with the BTK target is almost 5 to 8 times higher as compared to the first generation TKI. Apart from there, it also has lesser off-target activity. So it also does not cause inhibition into the EGFR pathways or the TEC pathways, which mainly causes the side effects. So that is the main reason why it is more efficacious and the less toxic as compared to the previous generation TKIs.
Right. Anybody wants to add anything or ask anything? So as she mentioned, it is highly specific. These are irreversible covalent BTK inhibitors. And Zanu is a second generation one. And testing against a panel of 370 kinases revealed that Zanu inhibits only 7 off-target kinases. So this is most specific, as Kinjal mentioned. And
Again, sir, one thing, sir, actually, as far as Acalabrutinib and Ibrutinib is concerned, sir, this Zanubrutinib, it is a complete BTK occupancy and it is a complete and sustained BTK inhibitor as compared to other counterparts.
Absolutely correct. This Nitin had shown this particular picture, and you can see how non-specific Ibru is as against the selective inhibition of off-target by Zanu by the red circles. So that is exactly what Dr. Panda just mentioned. How do its unique pharmacokinetics translate into the improved tissue saturation? Once again, the question is open to everybody. Dr. Panda has just answered a part of this question, but anybody wants to add anything?
Yes, sir. So, because as Dr. Panda said that the Zanubrutinib it ensures a very complete and more sustained BTK binding. So, because of that, it delivers also a higher fold of the drug exposure. There's more drug which is getting delivered, and it also has a very longer half-life. So, the activity is affected. It is much better because of these reasons.
Right. So there are 4 statements over here. One is related to plasma exposure. Zanu delivers 8-fold higher plasma drug exposure than Ibru. Then the prolonged half-life. So Zanu features a longer terminal half-life than Acala, 4 hours versus 1 hour. The tissue occupancy, which Dr. Panda had also brought out, this exposure ensures complete and sustained, put in the red here, BTK binding site occupancy across, and this is very important, both in the blood as well as the dense lymph nodes. I would also add bone marrow. So it acts all over. And constant level, the standard 160 milligram twice daily regimen maintains drug levels safely above the strict IC50 threshold, which is needed for uninterrupted pathway blockade. And again, Nitin had brought up the point that even if you give 360 mg once a day, it is equally efficacious and equally safe. The next question is, what real-world practical advantages does its metabolic pathway offer over other BTK inhibitors? So there's some statements here, but if anybody would like to take this up.
Sir, as far as Zanubrutinib is concerned, it is metabolized predominantly by the cytochrome P3A4 metabolic pathway. So it is actually not hampered by actually food. That is, there is no food interaction. You can take it with food, without food, in empty stomach, before and after. So it is also not affected by the acid reducing agents like PPI. Okay, unlike actually other BTK inhibitors. Then coming to the hepatic resilience, actually in childhood stage A, grade A and grade B, actually you don't have to actually modify the dose, but in actually childhood stage C, 80 milligram once daily, actually you can give with caution of this particular drug, unlike actually ibrutinib or acalabrutinib, which is actually you have to actually use with very much cautious as far as the atrial fibrillation bleeding concerned is adverse effect is concerned in liver impairment. Again, in kidney impairment, renal impairment also, this drug is very safe. If the creatinine clearance is more than 15 ml per minute, okay, so you can give it safely. Okay, then the FDA approved tablet formulation, it also reduces the pill burden, replacing the 4 capsules with 2 160 milligram film coated tablets once daily. You can take it either 160 milligram twice daily or 320 milligram once daily, depending upon the convenience. So
right. Excellent.
So most of the elderly patients are using a lot of antacids, like an over-the-counter usage is very common. So in those cases, acalabrutinib or even ibrutinib cannot be given because they do require that acidic environment. So in that ways also zanubrutinib is safer and better absorbed.
Perfect. So this is very, very important practical issues that acala loses its efficacy because poor absorption with PPI and antacids. And the liver part and the kidney part brought out by Dr. Pandey is also excellent, that you don't have to bother about reducing any doses. And one thing that can be exploited, like we do for venetoclax, that if you are using antifungals like posaconazole, the dose of this a bit relatively expensive drug can be significantly lowered. With 300 milligram posaconazole, you may give just 80 mg of Xano. And the last part, which was mentioned by both the discussants, is that in the Western world, you have a tablet, which is of 160 mg. So you have to just take one tablet twice a day. As against in India, we have the capsules of 80 mg. So you have to take 4 per day. So it does make, those who count the pills, it becomes important. The next question is, what do the 2026 long-term Sequoia results tell us about the frontline Xano efficacy? This was presented in the EHA meeting in June. So 2026 long-term, that is 6 years data about frontline Xano efficacy. Anybody?
So, sir, I'm Dr. Manoj, yes. So, as Dr. Nitin has already discussed, and you also in your opening remark only, looks like Xanu shows strong efficacy as compared to all other medicines which are available. So, at 2016 6-year update came, it shows both for high risk and non-high risk cases, it is very effective. Particularly in non-high risk cases, they have shown almost 75% progression-free survival. And also for patients who, as compared to the chemo comparison, where B plus R was compared with it, almost 72% reduction was there when they compared risk of disease progression or death was compared to the standard therapy. This long-term data confirms that patient initiating with the frontline Xanu achieved vastly superior PFS2 metrics compared to those who are going for the chemoimmunotherapy. So this is how it was. Yes.
Wonderful, wonderful. So, I mean, this is very impressive that in a newly diagnosed patient of chronic lymphocytic leukemia who is a candidate for treatment, at the end of 6 years, you got a progression-free survival in 3 out of 4 patients, unless you got deletion 17p. And if you got deletion 17p, again, 2 out of 3 patients will still be progression-free. So this is a phenomenon monotherapy efficacy of this BTKI. And again, as Manoj mentioned, 74% of the treatment naive patient remain progression-free at 6 years. This represents an impressive 72% reduction in the risk of progression or death compared to the BR, bendamustine rituximab, which is unfortunately even today used by a large number of consultants for their treatment of CLL. Progression-free survival 2, that is, when does the need for the next line of treatment occur, also shows you that Xano far outcomes all other chemotherapeutic, whether it is bendamustine, whether it is FCR, whether it is chlorambucil based, etc. So chemoimmunotherapy does not stand in front of monotherapy using Xano.
Sir, in addition to that, I would also like to add that even the 6 years data, it also showed a very good safety profile. So even if they were taking it for a long term, we did not see any additional toxicity signals which will make any concerns for our patient. Actually, the patient who tolerated it well, they lifetime did not have any other problems. So that will be again a good thing for me to give a lot of confidence in this drug. And the wonderful hazard ratio of 0.28, which is maybe one very nice. Like we have to accept that.
Absolutely. And we had a beautiful picture shown by Nitin, how every year the percentage of side effect keeps decreasing. So number of patients who will have hemorrhage or fibrillation or even infections or neutropenia kept reducing. The next question is, how does Xano alter the outcome of ultra high risk patients harboring 17p, which has been always a nuisance when you diagnose it in a patient who requires treatment and you see this, you're a bit discouraged and you tell patient that you don't have such good type of CLL as one would like to have. Yes, please. So this is a little bit of data put up for deletion 17p or TP53 mutated patients. Anyone?
So TP53 is a gene which we all don't like at all. And in most of the cancers or malignancy, whenever the report says TP53, before patient, we only see whether should we treat this patient or not. But Xano has given such a great hope in these populations that showing almost more than 60% response rate and over progression-free survival even at the 6 years. So it has been a new weapon in our armamentarium, which is like a super weapon for TP53. And it gives not only the better responses, it gives deeper responses. And that is more important in all TP53 malignancies, where the clonal level, it kind of eradicates the disease. So.
Perfect, perfect. Absolutely. You're quite right that TP53, you are disappointed when your patient has it, and your patient is more disappointed when you tell them the prognosis. Until yesterday, we always mentioned that giving chemotherapy to a patient of CLL who has TP53 or deletion 17p is shortening his life because you allow a lot of mutations to occur. Now, here is the data, as was mentioned, 2 out of 3 patients on Xano will remain progression-free at 6 years. So it is just little less than when you don't have deletion 17p, which was 75%, this is 64%. And as again Nitin had pointed out, Alpine, which is for the relapse refractory, and Sequoia, which is for the newly diagnosed patient, 96.9%, that is almost all patients have an objective response, irrespective of their genomic situation. And this is path-breaking, that at 6 years, most of the other combination therapies, today we talk about, all oral combination therapy with venetoclax, or we talk about venetoclax with the obinutuzumab, all these combinations, when you give them fixed duration, 1 year, 2 year, etc., the progression-free survival is average 4 years. While Xano monotherapy is 6 years. So when you have a poor prognostic CLL, Zanu monotherapy is far superior, gives you 2 extra years of progression-free survival than all those combinations which are venetoclax based. This must be remembered, that 2 is not better than 1 when it comes to PTP53 and deletion 17p minus. The next question is, how do the indirect trial comparisons position Zanu versus Acala in relapse refractory situation? I mentioned to you that studies occurred when Acala was not in the scene. So studies are against ibrutinib, but then indirect comparison exists. So one of you can take this up.
Yes, sir. So, in the indirect comparison studies where they have seen that zanubrutinib did reduce the risk of progression by 43% as compared to acalabrutinib, and also the remission rates, I would say, are quite similar. It's 93% and 90%. It's very similar when compared, but just the risk of progression or risk of death reduction is significant with zanubrutinib.
Yes.
Again, this is a cross-trial comparison, so it is not a head-to-head comparison. So it's not very reliable.
Fair enough. But as it was shown that Acala is equal in its efficacy to Ibru and Zanu is superior to Ibru, you can definitely make some sense out of this data. How does Zanu compare with earlier BTKIs, including Acala, from the angle of safety and toxicity?
So when it comes to Zana, sir, we all know that it is effective, but yes, as Dr. Kinjal also told in between her talk, that it is very safe as well. So we can continue that drug for at least almost 6 years. They continued in that trial with very minimum side effect. We know that ibrutinib, when it came, we all were like CML, imatinib. For CLL, we got ibrutinib, but it came with all this price of mainly cardiovascular side effect, atrial fibrillation, even discontinuation because of various side effect was very high. But when it comes to Zanu, as compared to acalabrutinib as well, it is very good. Though neutropenia is little more, but still it doesn't lead to discontinuation, and very minor bleeding, major bleeding episodes were very less in this trial for sure. So Zanu looks like it is the safest available BTK inhibitor at present.
Yes, very well said. So here you have a table, Zanu, Ibru, and Acala. Atrial fibrillation, Ibru 12% plus. Not only that, it even led to ventricular fibrillation and sudden deaths, which have been recorded. So always concerned about giving Ibru to elderly people, and majority of the patients with CLL are elderly. Acala came, this got reduced to about 4%. Zanu came, it got reduced to about 3%. So as you see, the safety of Zanu with respect to the most deadly complication, which can be very, very risky, getting atrial fibrillation, and maybe some of them can get a stroke from embolic, is minimized. And if you remember, I don't have that picture, but Nitin showed you, by the time you come to 6 years, the atrial fibrillation is even much lower than 3%. Out of the 2 cardiac effects, atrial fibrillation is the deadly one. Hypertension is something which is manageable. So it was 23% with Ibru, and peculiarly, this is one side effect with the passage of time increases in its incidence and prevalence. With Acala, it became half. With Zanu, it did not reduce, it increased. But because it is hypertension, it is so easy to manage. There is no problem in managing hypertension as against atrial fibrillation, which can be a life-threatening problem. Bleeding, 7%, 4%, and 3%. Major bleeding is overall rare, but half of that of ibrutinib. Discontinuation rate, Manoj spoke about. Every 5th patient discontinued ibrutinib. In fact, by now we have data that almost 40% of patients discontinued ibrutinib. With Acala, it became 14. With Zanu, it became 12. And again, Manoj mentioned about neutropenia. Yes, grade 3 neutropenia is highest with Zanu but febrile neutropenia or leading to morbidity and mortality was not different. So hypertension, febrile grade 3 neutropenia, more, but life-threatening atrial fibrillation, bleeding, which is major, and discontinuation rates show superiority of Zanu. The next question is, how do expert commentaries evaluate cardiotoxicity and the treatment switching protocol? We just talked about cardiac part, but as far as the switching part is concerned, Nitin had covered it. If somebody wants to discuss this.
So patients who did not tolerate well ibrutinib because of the atrial fibrillations or hypertension or other cardiac toxicities, the Nitin sir very rightly showed the slides that almost 75% of the patients, they did not get those side effects when it was switched to zanubrutinib. And even if they got it, it was at the lesser grade as compared to those. So patient can safely continue the zanubrutinib even after getting maybe side effects which were strong enough to cause the permanent discontinuation of the ibrutinib. So in that way, it is safer.
Perfect. Usually when you have adverse effects, you feel that the drugs belonging to the same group will produce same problem and you like to switch. But here you have, again, Nitin had shown, and as you mentioned, even with Acala having side effects of the extent that you had to stop the medication. If you go to Xano, and not to say venetoclax-based treatment, 72% of people, that particular side effect did not recur. And with Ibru, again, same thing, 60% in the blue part of the pie diagram, it did not recur. So here is an exceptional example that same group of drugs, the BTKI, Xanu, can be given to a person who could not tolerate Acala or Ibru to the extent of 60 to 70%. And the time to treatment discontinuation, we talked about it. The blue line is Xanu, the orange is Acala, and Ibru is the worst, which is at the bottom in the green. So from that angle, time to treatment discontinuation is least with Xanu. We are going to close this panel discussion, and I'm going to give you 3 case profiles. Some of these aspects were already beautifully discussed in today's presentation as well as panel discussion. So case 1 is a high-risk genomic, and you know high-risk genomic means TP53 or deletion 17p. Let's look at the first patient, 64-year-old man, progressive lymphadenopathy, profound fatigue, and worsening cytopenia. So he requires treatment. His workup shows a ultra high risk profile, deletion 17p and TP53 mutation. So a couple of years ago, you would have said that this is a deadly disease. We don't have too many answers. Chemotherapy will worsen it till you got a breakthrough in the form of BTKI. Historically, while treating the high risk patient like this, the mindset has been, even if you get some response, be happy. But a partial response in a patient who has TP53 mutation is a ticking clock. It leaves very unstable, highly mutated clone very active. And this paves way to the early clonal evolution, rapid resistance, and abbreviated progression-free survival. Therefore, giving FCR or bendamustine or chlorambucil to a person who's got deletion 17p or TP53 mutation is doing disservice. You are shortening the life because of the occurrence of this mutation. So the solution is, we cannot settle for a shallow response. We need the deepest possible clonal clearance to disrupt the trajectory. This is what exactly Xanu alters the clinical course. In a head-to-head data, Xanu delivered a 3-fold higher CRR compared to the older therapies. This isn't just a statistical metric, it represents a profound biological clearance of the malignant clone. So when it comes to deletion 17p or TP53, monotherapy with Xanu continuously being given today is the best solution, irrespective of all your combinations and all other older drugs. So when we look at the long-term alpine data, this deeper clearance translates directly into statistically significant progression-free survival advantage, especially with this ultra-high-risk condition. For a standard patient, a partial response might keep the disease at bay. But for this high-risk patient, Zanu gives us the absolute best chance of pushing it back the clonal evolution and extending the survival. 3 cases we are discussing. This is case 2 now. This is relatively simple, but a very practical issue. It was discussed already by our panelist. Here is a patient type that we see every day. A 76-year-old female, treatment-naive CLL. She has osteoarthritis and she has severe history of GERD. Now, to manage her reflux, she keeps taking omeprazole and also over-the-counter antacids. If you choose Acala for this patient, you are introducing an immediate silent clinical risk because Acala requires an acidic environment for absorption. Co-administering PPI is contraindicated because it severely reduces the drug exposure, risking the subtherapeutic target level and allowing the disease to progress. We cannot realistically police an elderly patient buying over-the-counter drugs and using them. For Zanu, you don't have to bother at all. Zanu's absorption is entirely independent of the acidic pH of the stomach. Whether she takes PPI, histamine blocker, or TUMS, her drug exposure remains 100% stable and predictable, so you don't have to really bother about this co-administration. In the real world, compliance is messy. Patients will take antacids regardless of your warning, leading to silent underdosing of Acala. Zanu removes this entirely, ensuring consistent maximum target occupancy without forcing the patient to choose between managing her GERD versus the CLL. We come to the last case. This is really the elephant in the room. Heart, and heart, the cardiovascular toxicity. And when you talk of BTKI, you cannot get away from cardiovascular toxicity. In fact, I've seen a lot of our colleagues, the moment you say the patient got a cardiac problem, then whatever is the cardiac problem, they just avoid BTKI. But here is a solution. So cardiovascular safety of Zanu. Consider a 71-year-old man who has controlled essential hypertension on, say, lisinopril, and he also has a mild, subtle, stable coronary artery disease. Okay. Now, when considering Zanu, the panel often looks at the roughly 15% or higher grade 3 hypertension. That this is the drug which increases the risk of hypertension and hesitates, worrying that this person who is already an hypertensive, his cardiovascular risk will increase. But we need to look closer at those cardiac signals which actually are worrisome. So this is a fundamental difference between a modifiable risk factor and a catastrophic cardiac event. Hypertension is the modifiable one. If the patient's blood pressure spikes, we can easily titrate the dose of lisinopril or add a calcium channel blocker. What we cannot easily manage is the sudden onset of atrial fibrillation or atrial flutter and the subsequent embolic stroke event, which frequently forces permanent treatment discontinuation with the first generation BTKI, and that we have seen how common it was when we used Ibru. Zanu maintains a significantly lowest risk of atrial fibrillation and flutter. As clinicians, we must ask ourselves, would we rather manage a predictable, treatable increase in the blood pressure or a dangerous arrhythmia which forces us to take off this treatment totally? Zanu gives us a safer, highly manageable cardiovascular profile. To conclude our today's discussion of last 1.5 hours, here we have Zanu, we have Acala, and we have Ibru from the angle of efficacy. So Zanu is the only BTKI inhibitor to prove statistically superior progression-free survival over Ibru in head-to-head trial. And indirectly, because Ibru and Acala are equal in efficacy, with Acala having no superiority with respect to PFS, Zanu becomes superior to both of them. Zanu achieved a statistically superior overall response over Ibru, and Acala did not demonstrate anything non-inferior to Ibru. Zanu significantly extended progression-free survival in the ultra-high-risk patients, as we just talked about. And lastly, indirect cross-trial comparisons show Zanu achieves a deeper response and higher CR rate than Acala. So progression-free survival, overall response rate, high-risk patients, and complete response rate. Zanu scores over both Acala and Ibru. From the angle of safety, we have already seen atrial flutter fibrillation Zanu, lowest incidence. Unique class toxicity. One thing which we have not spoken today, Acala produces headache in 30% of patients, which can last up to 3 months. Ibru, highest incidence of bleeding, while with Zanu, there is no headache whatsoever and severe bleeding is minimum. Gastric pH, we have already spoken, and BTKI target occupancy is 100% and continuous with Zanu, while it is variable and intermittent with the other two. So this is my last slide and the last part of this discussion this evening. Zanu redefines the standard of care in chronic lymphocytic leukemia. There is a definite case for Zanu superiority across whether you are dealing with a newly diagnosed patient or a relapse setting. It delivers structurally superior pharmacokinetics, leading to deeper clinical response and uncompromised safety. It delivers significantly higher plasma exposure than Acala, ensuring continuous therapeutic level. Its minimum binding to TAC, EGFR, ITK, and JAK3, relative to all historical competitors, established the fundamental reason for its safety profile. First generation agent like Ibru proved the pathway. Second generation agent like Acala sought to fix the safety. Zanu represents the third wave, optimizing the design for maximum efficacy and highest safety. So Zanu is not just another next generation BTK inhibitor, it is the BTKI to be used. In clinical practice, you talk about 4 things: efficacy, safety, ease of administration, and the cost. Zanu, superior efficacy. Zanu, better safety. Zanu, ease of administration. Cost, as I mentioned, if you have a cost issue with a particular patient, link it up with one of the, say, posaconazole, and you can reduce the dose to 25%. That is 80 mg. So that's the last slide. We can take off the slide deck. And if there are any burning questions, please go ahead and ask any one of the faculty. Or you want to share your experience, you can do that. It is 8:30, so we are just on the dot.
I would like to ask you regarding use of BTK inhibitors in CNS lymphomas, because there are a few studies coming up, and what is your experience?
Yeah, so if you have a DLBCL, which is the commonest lymphoma in the brain, and if it is ABC type, which is once again the commonest CNS lymphoma, then BTKI inhibitors, they cross the blood-brain barrier and they are extremely effective. If you have documented MYD88, it is like, so not, so there is a phrase there that it is still an additional benefit. So we used ibrutinib when it came for relapsed refractory patients of both primary CNS DLBCL and patients who had metastasis in the CNS from a systemic DLBCL. And today, Zanu probably again outscores both ibrutinib and Acala for this use. So this use is there for especially relapse setting and patients who are not fit for chemotherapy, even in upfront, again, both for primary as well as secondary, DLBCL, ABC type. And if you have MYD demonstrated, that's fantastic.
Sir, can we reduce the dose of zanubrutinib to 80 mg once daily with voriconazole also? Because the product also says
Voriconazole 160 mg, posaconazole 80 mg.
okay, sir.
I wanted to know about sequencing of these BTK inhibitors. So, like, if we have patients who are on acalabrutinib and they are progressing, so and they have acquired a TP53 mutation, so is it prudent to switch them to zanubrutinib, or we should add venetoclax, or like do a chemo and something like obinutuzumab and venetoclax, and like give a gap between two covalent inhibitors, or like what should be the sequencing?
Right. So if the problem is with respect to the side effects, then probably you can do exactly what you mentioned, that changing from Acala to Zanu. But if it is the efficacy issue that Acala has failed, in that case, going to Zanu may not be the best solution. In that case, you must switch to a BCL2 inhibitor, and that is invariably combined with a anti-CD20 antibody for the best efficacy. So yes, the answer will be venetoclax with rituximab or venetoclax with obinutuzumab. So that is not the ideal situation to go from Acala to Zanu.
But in case of intolerance, we can switch between the covalent inhibitors.
As was shown, after Ibru, 60% of people will not get that side effect. And after Acala, 70% of patients will not get that side effect. So you will be able to continue in 2/3 or 3/4 of the patient Zanu. There is a question by Dr. Krishna Ratnam in the chat box. Are there studies combining Zanu with venetoclax? Of course, Nitin brought that out. The arm 4 of Sequoia trial was nothing but Zanu plus venetoclax. So you have a 6-year data available on that. So very powerful combination. And that was a single arm study once again. The data is presented, published, it's all over. So yes, you have got Zanu plus venetoclax.
Is there any concept of stopping this indefinite therapy like a TFR concept for the BTK inhibitors, which you think can come into place, or can it be MRD directed?
Right. So overall, BTK inhibitors, when they are monotherapy, they are considered as a long-term treatment. They are stopped only if they fail or there is an intolerance. To have a fixed duration therapy, it has to be a venetoclax-based treatment. And that can be the standard, the most effective and the most time-tested is with obinutuzumab or rituximab. Obinutuzumab upfront 1 year, rituximab in the relapse setting 2 years. Some people can go with MRD and can give it a little longer. Some can continue venetoclax for a little longer, etc., etc. Recent data is with all oral therapy, where you can give venetoclax with one of the BTKI. The most important data that exists is with Ibru. Then you have data with Acala. And then just now, as we mentioned, the fourth arm, the D arm of Sequoia is with the Zanu. It appears that this combination is a bit inferior to obino-based combination. So if patient is okay for an injectable therapy and all the things which go with obino, then it should be obino with venetoclax. But if somebody wants all oral therapy in his air-conditioned bedroom, not come to hospital, not take injections, then it can be easily a BTKI with BCL2, which is a huge challenge because of its convenience and maybe little inferior, not very inferior. So these are all time-bound protocols. And then there is a little discussion on triplet, which I didn't bring up because no one has shown that the triplet in a long term is more efficacious in long term. And there's a definite increase in the toxicity as well as the cost. So triplet has not become a standard of care where you give BTKI plus BCL2 plus a monoclonal. But that has the fascinating results if it can be shown that it results into a long-term advantage.
So till now, sir, we were not routinely doing CLL MRD. So what is your take on CLL MRD? Like, how frequently should we do?
So no one has shown that if you become MRD negative, then it is equivalent to functional cure. Whether these patients relapse less often in long term is not clear. So you are not changing the MRD in CLL in clinical practice at all. This fixed duration therapy of 1 year and 2 years is very, very popular. US FDA approved, EMA approved, and used by you and me. First of all, MRD by flow, blood or in the bone marrow has to be of the quality that you can trust. The one with the NGS at the moment, nowhere has been standardized in India whatsoever. In US also, there is a single lab in Seattle, and the whole of US sends the sample to Seattle for the NGS. So I don't think it's practical. And if you can't trust your flow for MRD, then to take an action on that will be very difficult. So both multiple myeloma and CLL, I'm not chasing MRD today at all.
Yes, sir.
Yeah. So I think that's the end of it. We are grateful to Glenmark for putting all of us together and sponsoring this session, both the lecture and the panel discussion. It has been a good learning by interacting with each other. All of you were highly interactive. I'm grateful to you. The question answer session was also fantastic. The lecture by Nitin was also great. And I'm also grateful to the beginning of our Dr. Arora, Neeraj, who gave a wonderful talk on JAK negative erythrocytosis. So then, good night, everybody. And see
Good
you,
night, sir. Good night.
see you tomorrow. In fact, we've got 2 webinars tomorrow, 6:30. You're welcome.
Thank
Bye-bye.
you.
Thank you.
Thank you so much, sir. Thank you. Thank you all the faculties for joining. Thank you so much.